Hello, everyone. For
Hello.
most of you, this is good afternoon. This is week 3 of our quarantine. I'm fortunate enough to have with me my partner in life, Gorana Kuka Epstein. Dr. Gorana Kuka Epstein is a plastic surgeon. She happens to be my wife. That's why she has the same last name. She is an expert in hair restoration as well. And in particular, she has a particular passion for evaluating and treating women, not just with conventional therapies, as well as transplants, but also with some cutting edge therapies that she has been working on, which I'll let her talk about and explain. She also, fortunately, was kind enough to create a presentation that she's going to show us. Anyway, Gorana is from Belgrade, Serbia, where she did her med school and plastic surgery training. She's a voluntary assistant professor at the University of Miami, as am I. She's with the Department of Dermatology, as am I. I'm also with the Department of ENT or otolaryngology, head and neck surgery. Anything else you'd like to add about yourself?
I think you did pretty good announcement.
All right, cool. So anyway, we are here to not just provide as much information to this potpourri of participants that include former patients, potentially future patients, colleagues, plastic surgery colleagues from around the country, but also some friends and family. So to everyone, we're sending out a big hello and thank you. So as I said, everyone is muted. We're going to be doing some talking. We don't have a hardcore written protocol. We're going to be relatively lax about this. We tend to, I think, put on a good show. We've done this before. We have a teaching course and we've given lectures, and so I think we'll be hopefully smooth enough and clear enough. But at the end, we're also going to be able to open up the floor to questions. If those of you that are not as familiar with Zoom as others, is to be aware that there is a chat option when you go to the bottom. It's called, if you scroll down, at least on your computer. If you're on a phone, you actually have to move screens to slide screens over. If you go down to the bottom of the window, the page, you'll see chat, and then you can turn on a Zoom group chat, and you can send your questions in at the end, or any comments. We will hopefully get to them, and whether they're questions, we'll be able to reply to them, and or if they're comments, we will be able to share them with everyone. And so hopefully this will proceed smoothly. We've actually done several other webinars in the last week and last week, which have been which have had high levels of participants. So, and I think everyone's found it to be a worthwhile endeavor. So, with no further ado, I'm going to go ahead and turn over the floor to Dr. Kuka Epstein, who's going to give you an overview, and she'll talk about what you need to know and some of the things you can do to treat hair loss as a woman, things to know, and then what are the options for therapies. So go ahead, Gorana.
Thank you. Hello, everyone. It's nice to have you around, and I hope that you're going to learn a lot from this webinar that we put together. I see some familiar names that I want to say hi to. I also see some names here that I don't know. They seem to be from my surrounding countries that I also want to say special hi to. As Jeff or Dr. Epstein said, I'm essentially a plastic surgeon, but I developed this interest first in hair restoration, and then it followed with diagnosing hair loss and then treating women. So I put together a presentation that I'm going to go over and explain to you several things. First is how we diagnose a person with hair loss. So in order to treat it, we have to know the right diagnosis and what are the steps in order to have proper diagnosis, and from there, what treatments we suggest in our office. Can you pull up the presentation, please? So I will make a few breaks during the presentation. So if your question sort of matches what I'm talking about or what we are talking about, please use the chat to ask the question. And at the end of the webinar, we will have the open discussion, if you will. So since you're here, you're either facing hair loss yourself or you have someone around you that is facing hair loss. I hope this, what you learned today, you will be able to share with your friends, your daughter, your sister, your mother, whoever you know around you, that this can help. The fact is that 21 million women in the US have some degree of hair loss, then it does affect 40% of female population before the age of 40. It does not often come as a result from a single cause effect, but from a combination of factors. In my experience, all my female patients are very appreciative and very grateful for what we do. How do I, here we go. So the hair is a symbol of femininity, identity, freedom, beauty, liberation, and youth. And that is why it's so important for women. When I started my hair restoration practice, since I was mostly doing hair transplants, most of my patients have been men. But when women heard that magic word hair, they just started coming and asking for help. Etiology of hair loss in women comes down to many causes, starting from genetic hair loss, alopecia areata, psychological stress, emotional stress, hormonal disbalance, nutrition, inflammatory, and so forth. One of our colleagues from Canada, he reports 2,000 triggers of telogen effluvium, which I'm going to explain later on what it is. During our consultation, and we created together 6 years ago this clinic called Women's Center for Hair Loss. We offer specialized consultations for women they include detailed workup, attentive listening, thorough examination, and then we connect dots from our examination to what you're telling, what you're saying us what happened. You're a great listener. What I was taught is listen to your patient. She's telling you her diagnosis. This is pretty true. That's why we have a long form in our office where we ask so many very detailed and specific questions that you need to answer. And probably in 70% of cases, just from your story, we could tell what's going on without even looking at your hair. So these are the steps that we take in order to diagnose hair loss. You can see here the list. It's hair loss history, medical history, clinical examination, trichoscopy, trichogram, photography, hair tests, lab evaluation, allergy testing, and scalp biopsy. And I'm going to go over these steps. So when it comes to your hair loss, several questions that are important to us is when it started. And many women with hair loss, they can specifically say, okay, it started 10 years ago, or it started 2 months ago, it started after this event, or it was after what happened to me, or the surgery, and so forth. They can also explain in detail how it started, whether it was like clumps of hair coming out, or it was just like gradual thinning that led to a diffuse hair loss. Also, I ask, what are the specific areas where you see your hair loss, whether it's diffusely or it's in these, what we call frontotemporal recessions, or as my husband would say in very few words in Spanish that he knows to say, he would say entradas. Whether there is associated symptoms with that. And this is really critical because it tells us whether there is any irritation on your scalp. Irritation itself may be a cause of hair loss, and it can be a symptom of hair loss. So I ask, do you have burning, itching sensation? Do you feel any pain, tingling, and so forth? Then it's important how you care for your hair.
Can I just say something?
Yes.
Burning, calor, itchiness, pica, pain is don't.
Ooh.
Oh, no, inflammatory. I'm not sure. All right.
Can you put our picture there? Then how you care for your hair. So I'm going to also explain our recommendation, how you're supposed to care about your hair. The question is, Do you dye your hair too often? What kind of dyes are you using? Are you changing your shampoo every week, or are you using the same shampoo? So these are all components of that could impact your hair loss, and also previous hair loss treatments. Like, what have you done? How often have you done? Like, patients would say, I asked them, have you ever used a Rogaine, which is one of the medications? And so, yeah, I used that. How long did you use it? For 2 weeks, and it didn't work. Well, it couldn't work in 2 weeks. Next question is about your personal medical history. So history of family hair loss. You don't necessarily need to have a mother who faced hair loss, but someone there in your family could transmit the gene that led to your genetic hair loss. Also related to your personal medical history, have you had any surgeries in the past? Did you suffer from any illnesses? Are you just staring at me like that, or are you just attentively taking notes? I will later. And then drug history, and I'm going to go in this presentation over all the drugs that could cause hair loss. Here they are. So here's the list of most common medications that do contribute or cause hair loss. Number one is thyroid medications, and thyroid issues itself, they can cause hair loss. But then even while it's treated with thyroid medications, that also can cause hair loss. So I always tell patients, yes, you need to treat your thyroid issues, but those medications could have an impact on your hair loss. Then beta blockers, oral contraceptives. That's a very important topic because many women are using birth control pills. We do look into the ratio of progesterone versus estrogen in those, because some are more, some will cause more hair, some would cause more hair loss than the others. So we typically check what kind of birth control pills you're on to make sure if you, in agreement with their OB, could switch to a different contraceptive. Then other group is anticoagulants, retinoids, and anticonvulsant medications. In terms of your medical history, we ask about your diets, any crash diets. We always say whenever you lose weight, you also can lose hair. Vegans are a group that do face hair loss, I would say maybe more often in case they do not replace protein well. As long as you are a vegan, which we both are, I do highly respect that, but I also make sure that you are taking enough protein in your diet. And then, of course, the stress level. Probably many of you, if you experience acute hair loss, would know what preceded to that event, what kind of stress, either physical or emotional, you faced before that. Then there is clinical examination. And what I usually say to doctors that we train during our training program is make sense out of what you see. And this is a typical pattern of several types of hair loss, and that's what we're going to look at. Do we see any pattern? Do we see anything that is specific on your scalp that's going to lead us to diagnose your hair loss? And you, as patients, help us a lot by saying, yes, let me show you this, or let me show here, I see some changes, or if it's a patchy hair loss, you would be able to tell us where the patchiness is. We also, in many cases, we ask, is there any changes in your eyebrows, in your eyelashes, in your nails, and also in your skin? We examine the quality of the hair, quantity of hair, any scalp changes, and changes on the skin and nails, as I mentioned. It's mandatory during the consultation, and now we actually do it more with men as well, is to do trichoscopy, which is dermoscopy. And dermoscope is a little camera with a microscope that we can enlarge and take closely look into your scalp. We call it stethoscope for hair doctors. We do not carry stethoscope around because we don't, but we do carry dermoscopes in our pockets. So what we look when we examine your scalp with the dermoscope, we look into the quality of your skin. So is there any inflammation? Is there any dandruff? Is there any scabs? You can see here there is the change in coloration, and this is something we see very often. This is actually from hair dye. This is a person who dyed her hair 3 weeks prior to our consultation, and the dye is still there, and it's causing inflammation of scalp, which further causes hair loss. We also look into vascular pattern, which are blood vessels of the scalp, we can typically see, and then into hair shafts. Are they of even distribution? What's the ratio between thinning hair follicles and thicker hair follicles? And then we sort of come to conclusion what could be a possible diagnosis. You can interrupt me at any point if you disagree with me, or because I see your face and it seems like approval. This is what we use as a tool, and we always go back to, actually the best thing is to put together clinical diagnosis from what I just talked about, which is story, history of your hair loss, and clinical examination, and what we see with dermoscopy. Trichogram is an old test. We do not perform it because it's painful. It's basically to pluck 50 hairs of yours and then examine them, and I just refuse to do that. So that's something that was done before. We do perform photography, and it's very important because we can compare many things. First, we see only on the photo, and then second thing, we can compare what happened on your initial consultation and what happened 3 months later when we see you for a follow-up, because sometimes patients come and they say there is no improvement, and we compare photos and there is a huge improvement, and vice versa. So photography is our diagnostic tool, but it's also a legal tool. I'm sorry, I'm going to get someone. It's a legal tool when there is confrontation from a patient that there is no improvement there. There we go. Then we do several hair tests. We do a pull test, which is going to tell us whether you are currently shedding. Some patients do daily count test, which is to see in a week how much hair they are losing. And women are very particular patients, and I love them for that, because they would tell me, they say, I ask them, do you, on average, what is the amount of hair you lose? And they would say, oh, I lose 20 or 50 or 100. It is normal to lose up to 100, but if someone was losing none, and then there is increase in hair loss, that's definitely something going on. So I tell them to count and gather in a bag what they're losing daily for 7 days. We do a hair breakage test because we test actually how easily your hair breaks, and that tells us a little more about the structure of your hair. We do hair check, which is using a special device that's going to tell us that's going to measure thickness of your hair versus normal thickness. And wash test is basically to see what's happening after washing your hair. Some women tell us they lose more hair after their hair wash, and it happens especially in curly patients because they don't tend to brush their hair every day. So whatever they haven't brushed in 2 or 3 days is just gathered in very curly hair, and then it falls out during their hair wash. And that's not a legitimate test because it's just a accumulation of what they didn't brush out in these couple of days. Very critical, lab exam. This is the test that we ask our female patients to do. So we test for iron, ferritin, vitamin D, zinc, and CBC, and then for hormonal status, we do thyroid hormones, testosterone, DHEA, prolactin, estrogen, and progesterone. This should be done on the 2nd or the 3rd day of the cycle. Something that we are planning to institute in the next couple of, after this all thing with COVID is over, is allergy testing, because there is more and more ingredients of products that we are using that causes sensitivity of our scalp and even hair loss. And this all stemmed from the fact that some sun SPF creams with SPF cause frontal fibrosing alopecia, which is loss of this frontal zone of hair. And they found in those creams that they do contain an ingredient called titanium dioxide, which is connected with hair loss. So we're going to do this allergy testing to see whether something in your makeup, in your face creams, or in your shampoo is bothering your scalp, and maybe you're too sensitive to it. Hopefully this test is going to be available in our office as of June. So this is a typical test that we're gonna do. Most of these that I mark with an arrow could be fine in your shampoos or soaps or anything that you're using on your face or scalp. Specifically, fragrances mixes, paraben mix, and so forth. Sorry. Here we go. Lastly, so after all this is done, typically in 90% of cases, we sort of have a clear picture what's going on. But as they say, 2 doctors, 3 different opinions. If we're unsure, both of us, we do a biopsy. Biopsy is a small procedure where with this little punch, which is 4 millimeters, I'm sorry, I want to thank someone, which is 4 millimeters, we take a sample of the tissue in a correct depth, and then we send to a pathologist for a complete analysis. Typically, what we match is once we get that report, we match it with dermoscopy and with the entire story that we know about our patient. So we learn with every specimen we send, we learn further. All right, so I'm gonna take a break here. How do we, can you stop sharing before I go to treatments? Because that's the second part of it.
Sure.
How am I doing so far?
Great.
Great.
Yes, we have a question for you.
Yes.
We have from someone that said, how do you do allergy testing via blood work?
That's a good question. Actually, it became more sophisticated. We would put patches on your back and then have you return after 3 and 5 days. So those patches, I don't know how much you noticed, but they test for 35 ingredients. The test that we're going to do, there are some that test for 200. We're going to start with this smaller one, which contains most of those ingredients that are in your hair or face products. So putting patches on your back, we're going to assess the skin reaction to those ingredients. So it's a patch testing, basically.
Probably at least 50 to 60% of the whole process of treating women's hair loss, unlike with most men, where it's typically much more obvious. Now, this is not the case in all, this is not the situation in all cases with women, but generally the importance of the consultation and the history and just sitting down with the patients, at least I've found, and I don't know if that's your opinion, most patients find that to be perhaps one of the most valuable parts of the consultation, not just for us, but just an opportunity for our patients to be able to share what probably a lot of people have either minimized, including physicians and or partners. I don't know, what are your thoughts about that?
I agree, and
it's a very sensitive point.
It is, and I think it's underestimated by our colleagues and even dermatologists, because female hair loss is different than men hair loss. So that's why it requires a little, more thorough workup, so we know what's going on. And it's a combination of factors in most patients. That's why we cannot treat hair loss assuming it's genetic, but then there is a deficiency in vitamin D that we sort of missed and didn't see. So we just want to cover every single cause if that's possible, and then offer treatment, or at least, like, for example, I mentioned medications of hair loss, medications that could cause hair loss. And many patients do not know that birth control pills, if they have higher level of certain hormones, can contribute to your hair loss versus others that could not. And just that little switch in your birth control pills can do a lot for you.
All right. Proceed with approaching treatments, and then we have another question, but I think it'll be more appropriate if you talk about therapies.
All right.
So part 2 is, let's start from here, and hopefully we'll be able to continue from there.
Okay. So I think I covered most of them. So I'm also practicing in Europe, and in Europe we do have available more treatments. So I think I focused this presentation on those that are currently available in the US. So these two are the only two medications that are FDA approved, minoxidil or Rogaine or Regaine of 2 and 5%, and finasteride. Rogaine is probably the one that you have heard of already. It comes in 2 concentration, and it comes as a pill, as a lotion, and as a foam. Pill is something new that
It's actually old.
It's old, but
something to be said. So yes, it's actually old because it's original form. So.
Correct. That it just reminded me of something. You're right. But now they got back to that old idea how hair loss could be treated. So Rogaine comes as a lotion, and typically it is advised for women to use 2% twice a day. However, our protocol is a little different because we have female patients use 2% daily, and then after a month, if there is no excessive shedding or any other side effects of the medication, such as I'll go back to that, we switch them to 5%.
Once or twice a day?
Once a day, 5%.
I knew the answer for that, I just wanted to be sure.
And we tell them to use 1 milliliter and rub it into the scalp. Side effects
should it be used, at what point should you use it? Like in the morning, before the shower, in the shower, after the shower?
Good question. The only nuisance with the Rogaine is it makes your hair really greasy. In order to avoid that, we tell patients to put it in the evening before going to bed, rub it into the scalp so it doesn't sit on the hair rather, but goes down to the scalp rather. Rub it in, and before going to bed, have it like 30 minutes before you actually touch the pillow. Why? If it goes down on your face, if it goes down on your face, it might cause a facial hair growth, and it is temporary, but still it's annoying. And in order to avoid that, don't make that just go down. Don't make the lotion go down on your face.
Is there certain women that are more at risk for developing facial hair growth if they use minoxidil?
Yes, those with darker hair and also with some with higher level of testosterone, androgen.
Can you talk about PCOS? Because I don't think you really covered it. Polycystic ovarian syndrome.
I will. Let me just complete this. So you'll need to be patient. Be patient. Side effects. You asked me about side effects.
Yeah, you got that.
So I didn't cover them all. Some patients witness excessive shedding after first couple of weeks of using Rogaine. It is normal for hair to switch into their telogen phase after the initial use of Rogaine. However, if that lasts longer than 3 weeks, you should stop using Rogaine. It is thought that probably alcohol that is lotion actually mixed in causes this irritation. So if you can find a compounding pharmacy that can make Rogaine, which is not diluted in alcohol, that's a better solution. Some patients also experience irritation of the scalp because it is also due to alcohol. However, I've seen in probably 5% of my patients, our patients, that there are other side effects which are much more of a concern, which is heart palpitation, lowering of the blood pressure, which is initial indication for Rogaine, for minoxidil. So all these heart and pressure side effects tells us that you are definitely too sensitive to Rogaine and that you should stop using it. I think I covered most side effects. What was your question? PCOS, what did you want to know?
No, I just wanted to talk about it's more hirsutism of facial hair growth. It's a greater risk in women with elevated levels of testosterone.
Yes.
PCOS, polycystic ovarian syndrome. You know, we know is a risk factor. That's one of the things. It's acne, irregular menstrual cycles, which is a very
Obesity.
Sometimes, and of course, hair loss, facial hair growth with loss of hair.
Yes.
And so I'll let you, I guess I'm sure you're going to cover the therapy for that.
Yes, we do not typically treat, if there is hormonal disbalance that we see, we do not treat it because we're not endocrinologists, but we point that out to our patients to go to their OBs or endocrinologist and get a treatment for that.
Although we will put them on spironolactone.
Yes, correct. Then, so that's about the Rogaine. There's also a pill. So they did a study recently. They compared 2.5 milligrams versus 5 milligrams of Rogaine orally. And they concluded that 2.5% is as effective as 2.5 milligrams is as effective as 5, but has lower risk of body hair enhancement. Second medication is finasteride. It's a pill. It comes in a dose of 1 milligram. It is only for postmenopausal women or for those that are on birth control pills but want to try another treatment for hair loss. Spironolactone is something we mentioned that is advised for patients with slightly higher level of androgens. Spironolactone is anti-androgen, so in those patients lowers the testosterone and the DHEA. However, with this medication, your level of potassium should be controlled every 3 months because it tends to change with the use of this medication. We gradually put patients on this medication, so we suggest a dose of 50 milligrams a day, then switch to 100, and then hit 200 milligrams, which is the most effective dose. Steroid injections. Steroids can be used orally, topically, or intradermally. Whenever we see irritation of the scalp, which can be either dermatitis or just inflammation or even cicatricial alopecia, we would recommend steroids. You can get a lotion and put it on your scalp as recommended, or inject it intradermally in our office. We typically inject them monthly. Most common conditions to treat with steroids would be alopecia areata, so patchy hair loss. We do treat some forms of cicatricial alopecia, which is scarring alopecia, and also occasionally we do treat telogen effluvium and androgenic alopecia if we see any sort of irritation of the scalp or patient has symptoms. Laser light therapy. How about you cover this?
I'm so glad. Laser light therapy has been a therapy. Basically, it's utilizing laser light at a certain frequency. Applied to the scalp, therapies have shown that it causes several physiologic changes, which can lead to cosmetic enhancement of hair. Those changes include increased blood flow, stimulation of the mitochondria, and increased protein synthesis at the level of the hair follicle. This has been shown in studies. What's also been shown is that these three things, the increased blood flow, the increased mitochondria, which are the energy drivers of the cells, of the hair follicles, and the increased protein synthesis, which is actually more byproduct of having increased energy, can rejuvenate existing hairs. So it's not going to restore hairs that are dead, but it can go ahead and take hairs that are thinning and enhance them and basically make them look fuller. In general, laser light therapy in our experience works in around 60 to 70% of women. It's used at home using a portable device that can be purchased. We happen to private label our own, which we can sell for half the price that it's commercially available for. because we believe in it and we make it available for our patients. One 3 times a week for 15 minutes. It's got a portable battery pack, so that you don't need to be plugged in, exactly to one area. And basically, it's a cap that sits on it and it stimulates the scalp. It tends to work best, in my experience, for those with thinning, a lot of miniaturization. Also, some women that have excessive shedding. That's who we find laser light works best for. It also is effective in certain cases of male pattern hair loss. The nice thing about laser light, 2 nice things: it's a one-time purchase, and also it tends to work without any side effects.
How would you combine laser therapy with any other thing?
Well, for example, if a woman's going to use, or a patient's going to use laser light, and the problem with Rogaine, the biggest issue with that is compliance. Twice a day or once a day. For men, it's twice a day. For women, it's once a day. So what we advise them to do is, if you're going to use the laser, 3 days a week, you use the laser, and like an hour before you use the laser, rub minoxidil into the scalp. The 2 seem to work better synergistically. And of course, laser can be combined with other therapies like finasteride, particularly for men. I'm not a big fan of finasteride for women. In my vast experience, I haven't seen a lot of results. I know there are some dermatologists, including some very renowned hair experts, that do prescribe finasteride. It's not one of my go-to therapies. My go-to therapies tend to be laser, steroid injections, minoxidil, as long as the patient is going to be compliant, and then finally, I'm sure you're going to talk about PRP, and then of course there's the permanent solution, which is transplants. But hopefully we'll have a little bit of time to cover that. In fact, we got 5 minutes to talk about yours. So once you finish up, hint, hint.
Yeah, I just want to mention when I love laser therapy, when we have a patient with a condition called telogen effluvium, which is excessive shedding from unknown reason, or we haven't detected the reason yet, that scalp I call an earthquake scalp. So whatever you do on that scalp might cause additional shedding. If you inject PRP, which is platelet-rich plasma, that can worsen the condition. If you put Rogaine, when there is also a risk of excessive shedding, that can worsen the condition. So laser is the safest option with this kind of conditions. PRP therapy, probably the most known and the best known therapy
And just so you know, in a couple of days, Andrea, our nurse practitioner, is going to be giving a whole webinar on PRP. So she'll go into it in more detail, but you can just give a basic summary of it.
Yeah, so basic summary would be that we take your own blood and we concentrate platelets. We actually give you a count how many platelets you are getting, and then inject those platelets onto your scalp. Upon injection, there is a huge release of growth factor, a bunch of growth factors. I'm not going to go into basic science too much, which stimulate hair loss. With this therapy, which has been around for probably past 10 to 15 years, there is no developed protocol yet. However, the major question is how often to inject PRP, because as with plants, you don't want to keep injecting too much. So we typically inject the patient and then follow through and to see in 2-3 months what's the status. It is my observation that this therapy hits a peak after 4 to 6 weeks and then remains there for a couple of weeks, and then after 2 to 3 months needs to be repeated. It could be used for androgenic alopecia, some cases of telogen effluvium, some cases of alopecia areata, but it is a fairly effective therapy. And what I like best, it's not a medication, it's your own blood. So yeah, next question.
Can I add something?
Yes.
PRP we also use with all of our hair transplants. It's routinely done as part of the hair transplant. It's been our observation that it's helpful in reducing the incidence of shock loss or shedding. That can result from a hair transplant, which, even though it occurs with very low frequency, we like to reduce whatever we can. It also may speed up the healing.
Yeah, absolutely. Adipose injection is probably my favorite thing to do. It might sound weird, but fat can actually help your hair loss. What was discovered even 40 years ago is that areas with hair loss are also lacking that fat layer of scalp. So we now, as we can do liposuction and gather fat from different areas of your body can re-inject that fat into your scalp. Something that we have really done research, we've done research on that, and we're still, we have a current study that you can still sign in for, I guess, although our office is currently closed. We are assessing results from this, which we are actually getting. And typically my approach is one treatment at a time. I want to mention an important part, and that is supplementation. In case your diet is not well, you can always supplement what you need. So if your lab tests say you are low in vitamin D, we put you on supplementation of vitamin D. Same thing with iron and ferritin levels and zinc. Two supplementation we typically use in our office. My favorite one is called Viviscal, which contains some deep sea minerals and vitamins important for your hair. And the other one is Nutrafol that we also recommend to use. So I'm going to have you take from here. When is safe to do a hair transplant procedure?
Cool. I'm going to talk for just a couple of minutes, and then we're going to take questions. We have a bunch of them in the chat. So the role of a hair transplant is to restore hair once the existing hair loss has been stabilized and once we have a diagnosis. So it's important that if you are actively losing hair, that it's not the right time to be getting a hair transplant, or if you have any type of irregular type of hair loss, it's important that someone evaluate you, someone who's a knowledgeable person who can figure out and make sure that you are a candidate for hair transplants. Generally, the indications for doing hair transplants are mostly to focus on areas. We have a certain area that's thinning, that's in the most cosmetically important areas of the scalp, such as the frontal area or maybe the frontal temporal sections. Scars that are the result of most commonly prior plastic surgery like brow lifts and facelifts. Those can be treated, combined sometimes with scalp micropigmentation, which is a form of a semi-permanent tattoo, can also help cover up scalp scars. Slowly progressive hair loss, yes, as long as it's not active hair loss, and we'll typically go ahead and take steps. So, for example, a patient comes to me with some hair loss that is slowly progressive. Usually, what I will recommend, unless it's completely stable, is some form of preventative therapy, most commonly Viviscal or Nutrafol, and maybe laser. Use that for 2 to 4 months, stabilize the hairs, optimize their health, and then perform the transplant so that, as I mentioned before, we reduce the risk of having shock loss. Orbitally high hairlines can be treated in one of several ways: hair transplants and/or the hairline lowering surgery, which is a particular area of expertise of mine, where basically the entire hairline is lowered in a single stage procedure. To be a candidate for that, patient cannot have any thinning up front, and also must have a flexible scalp, and they're primarily looking for lowering, not a rounding off. We need to have reasonable hair in the donor area if we're going to do a transplant, and of course, establishing realistic expectations is very key. And that's, once again, when you come to an expert like us, you're going to know that you're going to have, or anyone like us, you know you're going to be treated appropriately. And then scarring alopecias can be treated, although that's a little more, that's a little bit more cutting edge, I would say, or experimental. At this point, is it all right for us to go to chat?
Yeah,
because we've been getting so many questions.
That's great.
Let me stop sharing. And then, okay. Oh, I'm sorry if the audio is cutting in and out. I just saw that. Okay, can you repeat the supplements you often use that help in a hair loss? Go ahead.
Yes, so I mentioned, depending on your lab work, if there is anything that is out of balance there, that will be supplement. Typically, it's vitamin D, zinc, iron, ferritin level. And then 2 types of supplementation that we use is, one is Viviscal. There is Viviscal regular and Viviscal professional, which can be only sold through doctors' offices, and there is Nutrafol. That's the second supplementation.
Question about using minoxidil with vitamin A, I think with retin A, a mixture of minoxidil with retin A or retinoic acid. What do you think? And how do you manage the irritation by minoxidil? but most of those products also come with a very low dose steroid. What's your thought about mixing retin-A with minoxidil?
Yeah, I like it actually. I do use back in my separate practice in Europe. We have a very developed compound pharmacies, and I like mixing it either. You can mix Rogaine with finasteride, with dutasteride, also with vitamin A, then with clobetasol, which is steroid. Just it depends on the patient needs. There was a recent study I'd like to mention that they compared the efficacy of Rogaine in patients who are and are not using aspirin. In those who are not using aspirin, actually there's better intake of Rogaine and better results.
Question about finasteride strictly forbidden for women.
Yes, in some ways, yes.
Because if they get pregnant, with a male fetus, there can be significant birth defects, sexual organ development is impaired.
Yes.
So that's one main reason I don't like finasteride, plus the fact that it doesn't work. But Kuka Epstein did mention it's primarily used for postmenopausal women.
Correct.
For those who are premenopausal that meet certain criteria that understand the importance of being on birth control. Then someone asked about minoxidil with microneedling.
Yes, there was a study. Microneedling actually is basically with the roller or derma pen rather. You create a bunch of little wounds on the top of your scalp, and those wounds they go into 1 millimeter, 1.5 of depth. There is a study that Rogaine alone versus Rogaine and microneedling once a week, that the latter is more effective. However, once you make all those wounds, you cannot use Rogaine for 2 days. So that will be 5 days of Rogaine, then microneedling, then a break, and then you continue with Rogaine. But it is more effective because microneedling is basically doing PRP weekly. Creating all these wounds help promote local growth factors, so you always have this healing effect and stimulation of hair follicles on your scalp.
Oh, should we have allergy testing and biopsy prior to scheduling a transplant? I did a consultation via victims. I do quite a few photo reviews. Sometimes I meet the patients on webcams, particularly now since our offices we're not seeing patients in person. We're doing actually a lot of webcams. In general, allergy testing is very cutting edge. It's not cutting edge. It's not even recommended for the great majority of patients. When I go ahead and I recommend a transplant, I am always going ahead and evaluating their likely etiology of a hair loss. If I think a biopsy is indicated, if I think a workup is indicated, I'll be able to make that assessment almost always from the history and photos. If there's any question, I will have the patient see a local dermatologist, assuming it's not a local patient, for a proper workup, which is very key before I will undergo a procedure.
I just want to say it's not that black and white. Clinically, when we see someone's hair loss, we could tell, okay, there's something going on that is not only androgenic alopecia. Then we have dermoscope to compare it, and then very often we exchange opinions and say, okay, let's do a biopsy if we have something suspected. We do not routinely do it because there is no need for that. In most patients, we can tell the diagnosis, right?
How about shampoos and other hair care products besides the vitamins? It's a huge industry. It's a multi-billion-dollar industry.
Yeah.
Maybe we want to talk about the industry in hair health versus, the role of hair health, how it's different, in terms of appearances, cosmetics versus just actual hair growth.
Hair health just follows mind health. That's my opinion. So first thing you can do for your hair health is just keep your mind healthy and try not to stress out. And that is critical in most patients. Whenever they're exposed to stress, they're gonna respond with their hair as their weak Achilles tendon in a way. If you all are Miamians or Floridians, what I can recommend is wear a hat, whenever outside, because a burn scalp also is an issue for hair loss.
Sunburns can associate with hair loss?
Yes, absolutely. So as you're putting sunscreen on your face, put your sunscreen, aka hat, on your and to protect your hair. That's two things that first come to my mind rather than a shampoo. I do like Viviscal. I personally do use Viviscal shampoo. I think it sort of boosts my hair. even more. Try to find, you know, whatever is without parabens, no sulfates. These are shampoos you want to avoid. One thing I don't like is changing shampoos too often, because every time you change shampoo, your scalp needs to adjust to a new concentration of ingredients. So I would stick to one shampoo, same as with soaps and toothpaste. Stick to one product for like 2.5 years and then switch it. Find something that works, that makes your scalp and hair healthy, and just stick to that and then switch to something else. And there are medical shampoos. There is a Neutrogena, there is a ketoconazole. These are medical shampoos. There, if something can be treated with a shampoo, it could. Shampoo itself is not a therapy. Like when you see those awesome commercials, say, oh my God, I washed it once, then it all went back. That's not a therapy for hair loss. It could be additional thing to keep your scalp and hair healthy, but typically it's not.
I'm actually going to disagree. I actually, with regards to the shampoo, I encourage my patients to rotate shampoos. I'm a big fan of Nizoral shampoo. It's an antifungal shampoo, but it also may have some topical anti-androgen effects. It's sold over the counter. Nizoral, 1%, 2% is by prescription. And I like my patients to use that maybe once a day, and then they'll use a volumizer shampoo maybe twice a day. A volumizer shampoo, twice a week. Volumizer shampoos, or like Nioxin is a volumizer shampoos. This is where we talk about hair health. It makes the hair look fuller. If the hair also has a better keratin coat, it's going to look fuller, things like that. Also, hair color. Maybe talk about that role of hair color in causing hair loss and or contributing to, or can it be done, and is it a risk factor?
Yeah, I'm not opposed to hair dyes. I would, do whatever you typically do. One thing you should tell your hairdresser is to wash it off really well. So once hair dyeing is done, make sure he doesn't leave dye on your scalp. Use organic colors, natural colors, whatever best you can find. Don't do it too often, like 4 to 6 weeks is appropriate. Don't bother your hair too much with all the strengtheners and this is there is actually a condition called traction alopecia that happens in those women who tend to wear their hair tight all the time. So I tell my patients, let it just go down, so you don't put additional pressure onto your scalp. Any nice website for how to take care of hair in medical aspect? Any good article? Yes, ours. There is a website called womenscenterforhairloss.com. So we put some thoughts there and wrote very useful things. Good article. Did we write anything on hair loss? Yeah, we did a couple of years ago. Yeah, there is a lot of information on internet out there, but try to be critical and look for experts' opinion rather than forums. And it just I think it's just overwhelming what is out there.
A lot of people love the term stem cells. Stem cells are obviously not the cure for everything these days. At this point in the United States, stem cells obtained from fat from an individual patient are not permitted because it requires manipulation either by chemicals or physically of the fat to get the stem cells. There are also other new therapies being introduced. There are other therapies being introduced, such as exosomes. A lot of this stuff is controversial. I think there's going to be, or maybe I'll leave it to you, but I'll share one point. I think it's exciting what's going to be happening for the treatment of hair loss in men and women. I think it's an exciting specialty right now because of all the potential innovations. You've touched upon them. Any thoughts that you want to share, Gorana, with what people can potentially expect or what they should keep an eye out for?
Cloning. Hair cloning is out there. Yeah, we are working.
Not out there. It's potentially out there.
It's potentially out there. Yes, I am really. I have a question. I'm actually very enthusiastic about this adipose tissue therapy, and hopefully by the end of the year we'll have more results of our current study. There was a great question from Ivana Kostic, how to maintain the results that we achieved. So hair loss, if it's androgenic alopecia, is a progressive condition. That's what we tell to all our male and female patients. It's gonna be with you throughout your life. So there will be always something that you will need to be doing to maintain your hair in case of this condition. For example, with Rogaine, and I know we disagree in this, but it's okay to agree that we disagree. My opinion is that Rogaine is effective for only such amount of time. And the question for most patients is like, how do I stop stop Rogaine? How do I stop using this medication? What's going to happen with all my hair I gained through this therapy? Is it all going to fall out? And the answer is yes, but you have to be smart to trick this medication and slowly taper it out. Meaning, if you have been using it every day, then start using it every other day, and then every 3 days, every 4 days, so your hair doesn't notice that you are taking off this medication. Meanwhile, you can replace it with something else and start doing something else for your hair. So it is a matter of a plan, depending, of course, upon your condition. You know, if it's frontal fibrosing alopecia, it's a completely different treatment plan. Or if it's alopecia areata, these, if treated properly, can be resolved within a couple of months. So hair is a commitment from both ends, from you as a patient and from us as doctors. That's the beauty and the curse of treating hair loss. I hope you can hear us, because many of you are actually saying that you cannot hear us. So hopefully you were able to hear us. Any other questions? Let's see.
Dr. Rassman of Beverly Hills, a good friend and colleague of ours, says that laser light does not work. He tried his office and there were no good results. Some docs say LLT works and others say no. Doesn't work with every patient. No therapy is guaranteed to work with every patient. We have a large number of patients that have definitely achieved good results. In order to encourage our patients to use laser light, and as a reflection of our confidence, we offer a 75% money back guarantee on the lasers that get purchased through our office, which is good for a year. This way patients can use it for up to a year. We've seen enough good results where we know that most patients are not going to return them. So that's where, you know, that's what our opinion. Bill certainly is a very bright guy, but everyone has a different kind of experience, and we clearly like laser.
Yeah. So in this ocean of hair loss therapies, the ones we just talked about are those that have clinical studies. So for each therapy that I mentioned earlier, there were clinical studies done. So those clinical studies have maybe showed different results, but they did show effectiveness. So that's why we always go back to those studies. I personally do not like recommending something that I just anecdotally heard that it worked in my, on my friend or someone else. I only, we are nerds and we just read papers and just use therapies that work. That's why our adipose tissue therapy, that is actually our initial idea, we see it working in patients, but we now are doing a research, a standardized, placebo-controlled study, and we are counting hairs to understand what's happening after 3 months, after 6 months, and after a year of this therapy, so we can publish our work and say, okay, here, after 6 months, you're gaining this percentage of hair, or after a year, you're gaining this percentage of hair. That's what you want. You want just clinical research that proved efficacy of certain therapy.
Someone just asked, what is FFA? It's called frontal fibrosing alopecia. One last question. This is going to be the last question we take, and then we're going to say goodbye to everyone. We use Botox on scalp as a hair loss treatment. Very controversial. Any thoughts?
I've read some studies. They were not very convincing. They were more case reports. So I would opt for no as an answer. So we don't. There is a rationale why some doctors might use it. We just haven't tried it. We've seen actually horrendous hair loss after Botox application on the head. That comes down to the same story about what are you actually sensitive to. If we're going to conclude, I just want to say that this is going to be online, right? This is going to be on YouTube. And I know you might have more questions, so feel free to contact us. You know, we're happy to answer your questions on whatever topic you would like.
Thank you for everyone for being, for attending. And it was a pleasure to see all of you. And once again, thank you. Any other last words?
Thank you.
Bye.
Stay safe, stay home.